today's lunchtime seminar. Just going to close the poll. So this seminar has been endorsed for one GR CPD point, and it's a privilege today to have Associate Professor Mark Taylor with us today. Mark is an Associate Professor in Health Law and Regulation at Melbourne Law School, and he's also the Deputy Director of Helix at Melbourne. Mark chaired the National Confidentiality Advisory Group in England and Wales for 5 years. He was also the Policy Advisor to the Health Research Authority in England for 3 years and a member of the drafting group for the OECD recommendation on health data governance. He remains an advisor to the National Data Guardian for Health and Adult Social Care in England. And today he'll be reflecting on the principles of data governance in healthcare and telling us why trustworthy governance is important to data-driven healthcare innovation. Thanks, Mark.
Thanks, Dawn. And thank you all for joining me this lunchtime and for inviting me to present today. I'd like to start by acknowledging that I am speaking from the lands of the Wurundjeri people of the Kulin Nations, the traditional custodians of this land. And I would like to pay my respects to their elders, past, present, and emerging. So as Dawn said, today I'm going to be speaking about trustworthy governance and why it's important to data-driven innovation in healthcare. And I'm going to start by acknowledging that I don't know what trustworthy governance is going to look like for you. Not precisely anyway. Now, this is in part because I don't know enough about what you do, who it involves, and how what you do may affect them. And we're talking about data, and I don't know what data you use, who it was collected from, who it relates to besides the individuals from whom it was collected, how that data may be important to them, or how it might be used to cause them distress, harm, embarrassment, their families, their communities, by you or by somebody else that got access to the data, authorized or unauthorized. Even if I did know all of these things, I wouldn't necessarily know what the individuals who provided this data expect from you. If you deal with researchers yourself, if you're part of the information governance system that supports research and healthcare innovation, then what's it reasonable for healthcare researchers to expect from you? What ought you to be competent to do? And if you're a researcher and you deal with data from research participants, then what's it reasonable for the research participants to expect from you? In what ways are you expected to be competent? And in what ways do they depend on you? Now, the questions I'm going to come back to, but I wanted to start by making clear that I can only hope to begin to address these questions in very general terms. And what I really hope to do through providing this presentation this lunchtime is just to prompt you to reflect on what it means to be trustworthy in the context of your own work, and point out that this reflection is something worth doing deliberately, consciously, because sometimes the expectations that others have of us are not necessarily obvious to us. So I'm going to give a few examples where this has proven to be the case. And good researchers, good professionals have found themselves in the space where, in the health data governance space, where they have acted in ways which were not consistent with what others thought to be reasonable expectations. Others didn't think that they acted in ways that they expected them to and that they depended upon. So before going into that, let's just have a word or two about why we want trustworthy governance, why it's important to data within healthcare. I suspect you will probably have answers to these questions already, but I mean, we want people to give data. We want people to give data up willingly. We want to promote trust. And one way to do that is to demonstrate the system to be trustworthy. And we want to promote trust not only in health data governance itself, but we want to promote trust in the systems that health data governance relies upon. You may have been following the recent controversy in the UK regarding proposals to make it mandatory to record alcohol consumption by mothers during the earliest stages of pregnancy, all stages of pregnancy, regardless of the level of consumption. You know, you don't have to think very hard to imagine circumstances where research using that data might be considered distressing or unwelcome by mothers. And if this were to be the case, then what impact would that have upon their relationship with the healthcare professional that was seeking this information from them? So we have responsibilities not only in relation to the health research we do and the innovation which we promote, but with regard to the systems from which this data is originally collected. So we want people to continue to trust, and we want that trust to be well placed. So there's also that professional responsibility we have to act in the public interest and to serve the community. We don't want any trust which is placed in the system to be misplaced. We have a duty to do what we can to ensure that the system itself is a trustworthy one. So there's a couple of reasons why I think trustworthy governance is important to data-driven healthcare. And certainly in relation to the first motivation, ensuring that people do trust the system, then there's some evidence that we may need to up our game. There's some evidence that people's willingness to contribute data may perhaps be falling. There was a study published recently in The Lancet Digital Health, which considered US and UK public willingness to share data, health data, in an anonymized form with different types of organization. I'm just going to try and get that up on the screen now for you. Let me make it slightly larger, and then let me move out of the way. Now you'll see on the bottom there, they cite results relating to respondents' willingness to share anonymized health information by a country and entity that would receive personal health information in anonymized form. And in this study, there may be questions which one has to ask about this study, but in this study, only 50% in the UK and only 25% in the US of respondents were willing to share anonymized personal health information with an academic or medical research institute. Now, encouragingly, academics still fared a lot better than many other organizations, but you can see in the top right-hand corner, the significant numbers of people who would not be willing to share data, even in anonymized form, for any person, any reason, purpose whatsoever. Now let me just come back. Now the researchers who wrote up this study speculate that despite the benefits of big data and technology in healthcare, the rapid development of novel technologies may have been received by the public with concern. And they say, growing commodification of patient data and public scandals such as Cambridge Analytica has increased awareness of the risks involved in data sharing. There are risks involved in data sharing, and we don't want to kid people about that. We don't want to protect unwarranted trust. We don't want to encourage trust where it's not well placed. That's the job of the con artist. So if we want to ensure that any trust is well placed, if we want to be able to encourage trust in the system, what are the requirements of trustworthy governance? Well, what's trust? The literature on trust emphasizes reliance on an expectation. You expect something to happen, you act in reliance upon that expectation, you trust. But you do so in the face of a vulnerability. You depend on something to act in a particular way, and if it doesn't, then that puts you at risk. So I expect the chair to take my weight, I trust it, I sit on the chair. If it doesn't, I hit the ground. If there's no vulnerability, there's no need for trust. So if you trust someone, you act in reliance upon an expectation that they're going to behave in a particular way, and in doing so will protect you from a particular vulnerability. You depend on them acting as you expect, and if they let you down, then you risk being harmed in some way. We do this 1,000 different ways every day. We trust the food that we buy is safe to eat. We trust the drivers on the road to act responsibly. We trust drugs that are prescribed to us are safe to take. And of course, not everyone trusts everything to the same degree. And we can see that in debates around vaccination at the moment, around the COVID-19 vaccine. And the concerns that have been voiced that not everyone is going to believe that a vaccine is safe, even if it is. There's a difference between trust, which is an attitude, and being trustworthy, which is a condition. A person or thing is trustworthy when trust placed in it is well grounded. We've got good reason to depend on something acting in a particular way. We've got good reason to believe that the vulnerability in question is to be protected. We can't always control whether people trust. What we do have within our control is whether or not we are worthy of it. And that's why we should be working towards a trustworthy system, and then seek to illustrate why the system is trustworthy and hope that well-placed trust then follows. So, how does trust relate to trustworthy governance? I think a trustworthy governance relates to a system that is built to assure particular kinds of behaviours. It's built to protect reasonable expectations regarding action and to protect the vulnerabilities that trusting creates. I think it's important to recognise at the outset that trustworthy governance does not remove vulnerability. If there's no vulnerability at all, then there's no need for trust. There are times when we seek to reduce a vulnerability. So when we go through airport security, for example, we are seeking to remove a vulnerability. We're choosing where to place trust. We're not trusting our fellow passengers not to try and kill us. We are trusting the baggage handlers, the people that are screening the baggage. We're relying upon systems to ensure that we're kept safe. What we're trying to do in that situation is remove unnecessary vulnerability and place the trust in those which we think are competent to protect us from the vulnerability that remains. We can't always remove all vulnerability. We can't remove the need to trust from the system entirely. We still need to trust the machines are working, the scanners are doing their job. But even if we could, we might not want to, because trust serves a purpose. A system which has trust within it can allow us to do things ourselves and through others that wouldn't otherwise be possible. In that way, trust can extend our agency. It can allow a discretion or freedom of movement that a trustless system wouldn't permit. Give a really simple example of this. Think about just hiring a babysitter. You could install a nanny cam in a room and insist that the nanny that's supervising your child stay within sight of the camera. That may remove some kind of vulnerability, but at what cost? What if they want to take your child to the park or to seek medical care? There are costs in denying somebody the freedom to act in your interest. So trust is about opening ourselves up to a vulnerability, but doing so in a way that hopefully introduces new possibilities for action that you do want. It's enabling, but it's not risk-free. So in the context of a data-driven healthcare system and a data-driven healthcare innovation, should we be aiming for trustworthy or a trustless system? It is, as I say, inevitably going to be a blend, because you're never going to remove the need to trust entirely, nor should you seek to. Even those systems which claim to be relatively trustless, such as blockchain, don't entirely remove the need for trust, because you have to trust that that which was originally encoded on the chain was accurate. So there's always going to be a vulnerability. We should seek to avoid the vulnerability that is unnecessary or unhelpful. And to be honest, in the context of healthcare and healthcare research, some of this is second nature. We know that there are more risks associated with identifiable data than non-identifiable data. We know that there are more risks with data held at person level than aggregate. That's why we strip out identifiers where they're not needed. That's why we aggregate data where we can. That's why when person level data is needed, we keep identifiers in a separate file to that containing the payload data and link through a pseudonym. We do all of these things to remove and reduce unnecessary vulnerability. But we don't destroy personal information where it's useful. There's nothing wrong with the vulnerability per se. As I say, it can be useful. But what we need to ensure is the vulnerability is a necessary one and useful, and it's protected through appropriate, competent behavior. We need trustworthy systems. So if trustworthy governance is a system built to assure behavior of a particular kind to protect reasonable expectations regarding action and protect the vulnerability that trusting creates, what are reasonable expectations in this case? What are relevant vulnerabilities? Well, I'll start by saying what I don't think they are. I don't think we currently recognise health researchers, IG professionals to have the same obligations that we impose on lawyers, accountants, and others who have what's known as a fiduciary relationship with their clients. Now, the word fiduciary itself derives from the Latin word for trust. And when one party holds a legal or ethical relationship of trust with another, then this can give rise to a fiduciary relationship in law. The classic description of a fiduciary is a person who undertakes to act for or on behalf of or in the interests of another. As I say, classic examples are lawyers and accountants. Characterizes these fiduciary relationships is a power differential or inequality between the parties. One party is vulnerable to another, and the vulnerable party is still required to impose trust and confidence in the other. Through the imposition of a fiduciary duty, the law seeks to limit ex ante the possibility of the vulnerable party experiencing harm. And the central duty of a fiduciary is that of undivided loyalty. Fiduciaries have a duty to act in the best interests of the principal. Is this a thing that we'd recognise to be a reasonable expectation of a health researcher? Undivided loyalty? I don't think it is currently expected or would be considered to be reasonable. But acting in some ways that research participants would consider to be disloyal and would not recognise to be in their best interests can be problematic. Take, for example, a trial which some of you may already be aware of, the PACE trial. Now, PACE was a randomised control trial that involved 641 patients suffering from chronic fatigue syndrome, co-led by investigators out of Queen Mary University of London, King's College London, and University of Edinburgh. The study compared the effectiveness of 4 of the main treatments for chronic fatigue syndrome and found that when added to specialist medical care, it was cognitive behavior therapy and graded exercise therapy were more effective than other forms of treatment, including specialist medical care alone. Now, the conclusions of the PACE trial were published in The Lancet in 2011, and the fact that cognitive behavioral therapy was found to work better than some other medical therapies and specialist medical care led to the results being mired in controversy. Activists with very strong views about the nature of their disease and what does or does not work in treating it never accepted the results of the trial and have attempted to discredit the conduct of the trial and those who led it. I'm not going to comment further on the specifics of that particular case, but what I want to invite you to do is to consider what are the reasonable expectations that we can have of researchers in the circumstances. where research findings are unwelcome by research participants. I think few people would think that researchers have an obligation only to report findings which are consistent with what the participants want. I don't think many would think researchers have an obligation to act with undivided loyalty to research participants, only doing what's in the participants' interests. Researchers also have a duty to research integrity. If well-conducted, high-quality science finds something that research participants don't like, don't want to know, perhaps even puts them in a worse position because an inference is now being drawn about them that wasn't before, is that okay? Well, maybe, sometimes. I think there are obligations that a researcher owes participants. While not perhaps undivided loyalty, I'd say that there are ways to act that a research participant has reason to expect and can be given reason to accept as reasonable in the circumstances, and which in fact respects their expressed preferences in all but the most extreme circumstances. So I would and have suggested that this triple test of expect, accept, and respect can be a useful one when trying to determine what constitute reasonable expectations in a circumstance. I propose that one should be confident that research participants have a reason to accept your action as reasonable, even if the findings are not what they would prefer, even if, in fact, it's not what everyone does, in fact, accept as reasonable. It may be possible to demonstrate a research participant has a reason to accept a research finding they don't like if the research question itself was one that they expected to be asked, as in the PACE trial. It's more difficult, though, if they had no reason to even expect the question. Here I'm going to look at another example. Some of you might be aware of the research that was conducted with the Havasupai Indians in North America. Genetic research was originally carried out to investigate the link between genetic characteristics in the tribe and a very high rate of diabetes. A consent form was used to authorize the research, which authorized the study for causes of behavioral or medical disorders, clearly much wider than diabetes itself. Subsequently, other kinds of research were carried out using the data and the samples which had been obtained from members of the tribe. Subsequent research investigated links with mental illness and with the tribe's ancestral origins, finding their ancestors had travelled across a frozen Bering Sea. This itself was inconsistent with the tribe's own origin story. They live in the Grand Canyon in North America, and their origin story had them originating there, not elsewhere, and travelling across. When the Havasupai learned of this other research, a number of members of the tribe were distressed. They didn't expect this research to take place. They had left themselves open to a vulnerability, and it hadn't been protected. I think this does seem different from the PACE trial. While within the terms of the consent that was given, it seems more reasonable to say that the researchers acted in ways that were inappropriate and inconsistent with the reasonable expectations of the research participants. Although the researchers themselves, at the time they carried out the studies, clearly thought that they were doing the right thing. They were acting consistent with the terms of the original consent. Although it was consistent with the consent that had been given, the Havasupai in this case could be given no reason to accept this research to be reasonable. So what is it reasonable for research participants to expect of healthcare innovation and for healthcare researchers? I think it's reasonable for them to expect more than simple compliance with a broadly expressed consent. It's reasonable to expect more than minimum legal compliance. It's reasonable to expect that we understand the vulnerabilities that they expose themselves to when they hand over data, and for us to be competent to act in ways that protect them. This doesn't mean always doing what they would want. It doesn't mean acting with undivided loyalty. It does mean ensuring that we only do things with their data that they have reason to accept as appropriate. And it's also recognizing that what they may have reason to accept and what they may not always be obvious to us, particularly when we are preoccupied with doing what we are convinced is the right thing. So I'm going to give one more example. And this is the example of healthcare innovation in the context, again in the UK, in the context of the NHS, when NHS Royal Free Foundation Trust engaged Google DeepMind to do some processing for them. And clinicians in the Royal Free, well aware that acute kidney injury is a significant condition affecting 1 in 6 of the patients and killing many every year. They knew that within the data that they held within the hospital systems, there was the data that provided the opportunity for early indication of those at most risk of acute kidney injury, early intervention, more successful outcomes. But they also knew it was really quite difficult to pull together, to piece together all the different data from across the systems and present it at bedside in a way that was easy for clinicians to act upon. They didn't consider themselves to have the expertise in-house to develop the system that would allow for that to happen. So they contracted out. They contracted out to an organization they thought was competent to do that kind of work. That company was owned by the Alphabet Group, by Google. They provided personal data of around 1.5 million patients to Google as part of a trial to test an alert diagnosis and detection system for acute kidney injury. And the Streams app that was developed has apparently shown signs of improving patient care. These were clinicians trying to do the right thing by their patients, but there was considerable fallout. Here's behind me are just a couple of the headlines from the media at the time. Google DeepMind shouldn't suck up our NHS records in secret. Google handed patients files without permission. We have to know what people are sensitive to. We have to be ready to demonstrate the value of what's being done. The value proposition has to be clear, and we have to be able to articulate any risk to be a risk which is worth it to the data subject. And I think that's what the clinicians in Royal Free, although extremely well intentioned, failed to do. They failed to recognize just how sensitive people were to the sharing of data with an organization that was owned by Google. They failed to convincingly articulate a value proposition that made it apparent to all why the risks which were inherent with that, or at least perceived to be, were actually worth it. If we want a trustworthy system, then we want a system that individuals have good reason to trust. This is a system that, as I say, does what they have reason to expect and to accept as appropriate. Okay, now I'm going to skip ahead a little bit now because I'm just conscious of time and I want to leave plenty of time for discussion. A few years ago, I did some qualitative empirical work with Vicky Chico at the University of Sheffield and Amanda Hahn at the Health Research Authority. And we wanted to explore public views on sharing, again, anonymized data, well as mixed public and private benefit. And we found that people would prefer data wasn't shared with commercial partners, generally speaking, but they understood that that could sometimes be useful. They weren't, and when it was useful, they weren't generally hostile to the idea of there being a private benefit. They were hostile to the idea of there being a disproportionate private benefit, of there being profiteering, and there was some skepticism about the ability of public bodies to effectively negotiate with significant private partners. And I think Lancet studies suggest that opinion might be more hostile now than it was then. And I think there is grounds to believe we may be losing some faith in the traditional tools of consent and anonymisation. While both ask and anonymisation remain important, neither of them are cure-alls, not by a long way. But what we were able to establish through this research was that there is a difference between what people prefer and what they're willing to accept when they're given good grounds and they believe that on balance, the sharing is actually in the public interest. There is reason for it, and the risks are worth it. So return to where I started. We need to know what people expect. We need to be able to establish which of their expectations are reasonable. Need to understand the vulnerabilities that people expose themselves to when they entrust data to us, and to be competent to protect them. We have to understand those risks and consider the motivations of bad actors and the perceived risks of partnerships with commercial organizations, of international transfer, perhaps even of using companies which aren't going to transfer data internationally but have international links, as was demonstrated recently in relation to the COVID Safe app data being handled by AWS with its US links. We have to understand these concerns and these fears, even the unfounded ones, before we can demonstrate that people have reason to trust the system. This isn't all on researchers, this isn't on IG professionals, the legal departments of universities and other research institutions, or ethics committees. No one part of the system has responsibility for doing this. We have to think at system level about how we can work together to work in concert to ensure that we understand what the expectations are, we can articulate the reasonable ones, and we can have a robust, competent system to address the risks that we want to keep, the vulnerabilities that are useful and necessary. In order to do this, we have to talk to people. As Dawn said at the outset, I was involved in the drafting of the OECD recommendation on health data governance. And the very first thing that we said in that was that engagement and participation, notably through public consultation of a wide range of stakeholders, with a view to ensuring that the processing of personal health data under the framework serves the public interest, is consistent with societal values and the reasonable expectations of individuals for both the protection of their data and the use of their data for health system management, research, statistics, or other health-related purposes, serve the public interest. That's not easy, but it's important, because what are the views about what is reasonable, the views of what constitute the vulnerabilities, the relevant vulnerabilities, and an acceptable trade-off is not always obvious to us. We need to talk to the people whose data we're using. So I started by asking, what is it reasonable to expect of ourselves and others? And I've suggested that trustworthy governance is a system built to assure behaviour, to protect expectations relative to vulnerability. Accepted that we have reason to accept vulnerability in the system where useful or necessary. We shouldn't be trying to design it out entirely. We should ensure that the vulnerabilities sit in places where there's competence to protect it, though. There are times when we do want to reduce the need for trust, and we have things like virtual labs designed to prevent people taking data out of systems, processes that allow for analysis to be taken to data rather than data to the parties that want to do the analysis. And these can be all appropriate ways to reduce the need to rely upon people to act appropriately, to reduce the need for trust. But they all come with some limitations and some costs. We need techniques that reduce unnecessary vulnerability. Where vulnerability serves a purpose, we need trustworthy governance. But what we need to be able to do is articulate why that vulnerability is useful and ensure we have the competence in the system to address it. This isn't about strict compliance with consent. It's about going beyond simple anonymisation It's about recognizing the interest that people have and that they perceive in their data, and it's being clear about the obligations we have to be competent to protect those vulnerabilities. Not undivided loyalty, but something that goes beyond just doing good science. At the very least, I think we have a reason to expect researchers to use data in ways that participants have reason to expect, to accept to be fair and reasonable, and which respects their expressed preferences. And that's why I think would be on the clipboard of anyone that was evaluating the system for its trustworthy governance. So this isn't easy. The vulnerabilities are not always obvious, and nor always the ways to protect them. But if we don't do it, the biggest risk here, I think, is that trust is going to be misplaced. And really, that's not in anyone's interest. Okay, thank you.